All right, thank you so much. Here, the program still this morning on ITV. Now, we talked about the issue of COVID-19 some time ago, and of course, because of the insecurity situation in the country, it seems that we were just leaving it apart. Well, we've not left it apart. COVID-19 is still in Nigeria, and of course, there is still need for us all to ensure that we still go on the non-pharmaceutical protocols, observations, so that we can actually, control COVID-19. But there is something that we need to talk about now, talking about the possibility of the third wave in Nigeria. As a matter of fact, only yesterday, the Presidential Steering Committee on COVID-19, actually, notified that Nigerians have to be very careful so as not to go through the third wave of COVID-19. Now, we've got various variants of the coronavirus, all around the world. As a matter of fact, some nations of the world, they don't talk about the first, second, and the third variant anymore. They are talking about the fourth variant of the COVID-19 vaccine. Now, India as a nation is going through a very difficult and challenging time. We understand that because of their population, the third wave of COVID-19 in India is so devastating to the extent that we heard that victims line up for oxygen gas so as to survive the situation. Now, if you recall, we've always been concerned about the population of India that stands at 1,393,409,030. That's the total number of population of India as at 2021. You can Google that out, and of course, you'll find out for yourself. Now, for Nigeria, it's just above, a little below 200 million. That's what we are told for the population. Now, the concern here is that for most people, not that Nigeria has the same population with India, but the fear is that if you look at the population demography, when we talk about the population demography now, we're talking about the population characteristics in terms of population settlement of India and Nigeria. They have the same demographic structure with India. So the fear is that if we have a third wave of COVID-19 in the country, it is not going to be easy at all. So that's the reason why that experts are beginning to warn us that we should ensure that we have to be very, very careful so as not to go through the third wave of COVID-19. Well, to go through all this with me this morning, we are so privileged to have Dr. Pius Ononigwe, who is the CDC. Now, the CDC is not a political party, it's not an acronym for political party, but it is the Center for Disease Control. CDC epidemiologist in Edo State here with us this morning. Dr. Pius, you're welcome to the program this morning on ITV.
Thank you so much.
You're welcome to the program. Now, if we have time, we're going to be letting our numbers out, our WhatsApp and SMS number out, so that you can also have your say on the issue that we are talking about today. Now, we're going to be looking at COVID-19 in Nigeria, the fear of third wave. Now, you're welcome one more time. Now, let's look at the status quo, most especially as it relates to the COVID-19 situation in the country. Now, we understand that the vaccination, at a point, it started, but somehow, some say that the federal government issued a directive that the vaccination should be suspended, most especially as the AstraZeneca vaccine was the vaccine that was used. What is the status quo of the vaccination in Nigeria today and of the COVID-19 situation in the country?
Okay, thank you very much once again. Of the Africa Center for Disease Control and Prevention supporting the Edo State COVID-19 response. The vaccination situation in Nigeria, we recall the last time we did a rollout where we received as a country barely 4 million, about 3.9 million doses of COVID-19 vaccine, the AstraZeneca type, Oxford AstraZeneca. And you know the Oxford AstraZeneca is a 2-dose vaccine. So obviously that's roughly 4 million doses of the AstraZeneca. We expected that we should be able to use it for about 2 million people, because you do one dose and keep the next one for the second dose. So obviously, as at present, we had a national rollout for vaccination sometime in March into April this month, and presently we have been able to immunize, vaccinate about roughly 1.2 million Nigerians. Obviously, the target should have been about 2 million or maybe 1.8 million, considering the fact that we had close to 3.9 million doses that should have given us maybe probably 1.8 people, first dose, at 1.8 for the second dose. So, but the point there is that we have been able to deploy these vaccines to the tune of getting up to 1.2 million Nigerians getting their first dose. And we're expecting that in the next couple of weeks, you know, there is an interval between the first and second dose.
What is supposed to be the interval?
Is actually between 6 to 12 weeks. But we have established that the longer it stays, that's if the longer the interval between the first and second dose, the more the immunity the body produces.
Is that scientifically proven?
Yes, it has been scientifically proven. That's why we are like when we started, we chose the option of 12 weeks. So, like my own appointment is after 12 weeks of my first vaccination. So, and that's what we have adopted. And the reason is very clear, because we are still having issues on how long the immunity lasts. But we have evidence that the longer the interval between the first and second dose, the more the immunity you build, the acquired immunity. So, we have done about 1.2 million generally in Nigeria. Here in Edo State, we received also about 81,000 doses, 81,540 doses. So from that 81,540 doses, about roughly 81,000 doses we got, we have we had understanding even earlier before it was said that we should keep 50%. We have already done roughly 34,000. We have already done roughly 34,000 vaccination for residents. Then we have the balance. We are also gradually, because what issue of hesitancy, the remaining balance we have, we are giving it to people, health workers, because health workers are now beginning to clamor for. So,
in other words, you are still in the first jab.
Yes.
The vaccination in those states is still on the first jab.
But obviously, because it's a campaign, we have ended. But this, you know, the issue of hesitancy is something that we are gradually resolved. So we have pockets of centers in Edo State where we are also giving people who are eligible, specifically healthcare workers and frontliners.
So in other words, you are still on the first jab with the vaccination in Edo State?
Yes.
Okay. So when likely do you think you are going to commence at the second jab, I mean the second dose? Because that seems to be a major concern for most people that have taken the first jab. For some, somehow they are beginning to lose faith that the first jab was given, they don't know when they'll be given the second jab. Are you communicating with them to give them some form of assurance?
Okay, yes. You know, the last time I came, I told you that our strategies for the vaccine deployment, they are very, very clear and well planned. I said earlier that we have, for the first phase, or the first dose that we rolled out, we had already kept the ones for the second intact.
Okay.
And in fact, they are in the code. The code storage is being monitored regularly to ensure that there is nothing, because apart from securing it, what of the storage? So we have secured it, number one, and we are actually monitoring the storage to make sure that the temperature of 2 to 8 degrees Celsius is actually maintained.
Okay.
So that one is not an issue that has been kept since. So what we are talking about is when the appointed time, because I told you that we adopted the 12 weeks. So most people, I think sometime in June, July, that's when people's appointment will start coming there
for the second dose. Okay. Now, there's something that was need to know. Now, at a point, we understand that the federal government suspended the usage of the AstraZeneca, and that was when we started hearing of the introduction of that talks were ongoing, arrangements were being made to introduce the Johnson & Johnson COVID-19 vaccine as a single dose. So for most Nigerians, it's somehow rather confusing. I mean, AstraZeneca started, then somewhere along the line, they hear that somehow that the federal government suspended it. Talks with going on to introduce Johnson & Johnson. So what is the status quo as it stands now?
Okay. Actually, I think the information was not well conceptualized. There was nothing like federal government suspending the use of AstraZeneca, because if you recall, that's what we are using. In fact, as at yesterday, some states, including Edo, got some extra supply from the earlier stock we have. Then we got close to 9,000 plus doses, which we want to start deploying immediately to the eligible population. So what happened was that the Oxford AstraZeneca that we were supposed to receive, obviously we had 4 phases. We just finished with the first phase. We had the second phase that would have covered almost 10 times what we were able to cover here, what we were able to cover in the first phase. So the Oxford AstraZeneca was supposed to be used through the COVAX facility and the rest, and India played a very good strategic role in the deployment of this vaccine. But after a while, they also foresaw that cases were rising, the demand was getting high. So they said they were not going to meet up with the supply agreement.
Okay, because they needed it more.
So they needed it more, which was right. They needed to have also their people protected, and there was serious emergency, which you can now see the evidence now. Although we, in epidemiology, when things happen 1 month ago, we already understand it. So they knew that, and they said they were not going to honor such agreement. So of course, Africa, we have not. That's actually that issue that we're trying to strengthen. We don't have vaccine production for COVID-19 as an advantage. So India said they could not, which was understandable. We had to now, through the African Union and the COVAX facility, start looking for alternatives. So that's why the Johnson & Johnson issue came up. In fact, I think we'll be expecting about 29 point something million Johnson & Johnson in a very short while.
Okay.
But the AstraZeneca was actually not suspended, but because these suppliers could not give, because the need was more in their own country as they perceive. So that's why federal government could not continue with the agreement to get from India. That's the Oxford AstraZeneca.
Okay.
So you can see that there's no suspension here.
Yeah, but the efficacy of the AstraZeneca, it's very, very much in doubt. I must let you know by going by what people say. Because, I mean, what India is going through now, India is going through a third wave. Now, the population there is mad. There's no doubt about it. And of course, the population of those that are down with the COVID-19 is also high. So if a vaccine like the AstraZeneca is that effective, so why do you think we still have that heavy population of people getting infected with the COVID-19 in India?
Actually, this is not rocket science. Any vaccine any COVID-19 vaccine that is actually approved for use is effective. That's why we don't say Oxford AstraZeneca, Johnson & Johnson, Pfizer, BioNTech. Once anyone is available in a country, for it to be available in that country means that it is good for use.
Okay.
So obviously there is no issue. The Oxford AstraZeneca, as you said, for the fact that the regulators have said the benefits far more outweigh the risk, continue to use. So one cannot come and say it's not actually. Yeah, but the issue now, let me address the issue.
Yeah.
The issue is that we ask yourself, how many population, what proportion of India's population have been vaccinated, and what was India's approach to non-pharmaceutical intervention and other things before these serious surge.
Yeah.
Now, India has barely vaccinated about a population of about 1.4 billion. Close to 1 point, and they have barely vaccinated 100 and something million. So if you like, you could say about 10% of their population. So what happens to the 1 billion 200 and something million people? Those are, you can see that they are vulnerable. So with that 10% proportion of their people, 10% of their population immunized or vaccinated, that does not give them so much stand, because 90% are still vulnerable. So anything that that favors the spread of the virus will obviously have a stimulus time in terms of a spread. So I think that's enough. And also, what is the regulation? What are the non-pharmaceutical interventions that are being practiced in that kind of population? So I think just as I said earlier, the 10% population proportion is not significant enough to block whatsoever. Now, just like in Nigeria now, if you check out data, we are barely doing, I can't say we're even up to 1%, but we are barely doing 1% of our population. We have done close to 1.2 million, or 1.2 million, and we are 200 million plus. So you see that we are still trying to see if we can do up to 5 to 7%, 0.5 to 1% of our population. So
all right, viewers out there, the program is This Morning on ITV, and we're looking at COVID-19 one more time, looking at the fear of a third wave. You know, a third wave, most countries of the world already going through the third wave, and the fear of the third wave in Nigeria here is what we're looking at. Now, we're not going through the third wave here, but experts are beginning to posit that if we don't do the needful, we may just also go through the third wave. Now, Dr. Pius Ononigwe, now, what modalities do you think that the government should begin to put in place now? The government, individuals, so that we don't experience the third wave that we're talking about.
Okay. Actually, the modalities are very clear. Number one, we need to understand where we are in terms of our own response, nationally, subnationally. Yeah, I think nationally, the incidence of COVID-19 has actually gone low, because when you talk about wave, talk about when it rises, when the cases are rising over time, how long they are sustained in that rise, and when they begin to fall, and when they plateau to a very low point, how long it's sustained. Then if it's sustained for a very long time, you can say you have actually come out of a wave. Then if you begin to see another significant rise again, talk about another wave. So in Nigeria, we have actually, when you see the data, we have the epidemiological curve and the rest, we find out the positivity rate, all those indicators, we find out that we appear to have actually contained the second wave.
Are we doing commensurate testing?
Yeah, actually, nationally, the target is to see how we can test at least 1% of our population, which is 1% of our population should be about testing, say, 2 million people.
Yeah. So,
but I know some states, like Edo State, we have tested more than 1% of our population. So at least if you're able to test 1%, which is still very poor, you could now make some generalization with that. But we are not doing, of course, we are not doing, that has always been an issue. So, but if we're able to do 1%, we could use it to make some reasonable inferences. Now, we have been able to, using those indicators, see that for now the incidence is low and it's been sustained. But that notwithstanding, there is possibility of a resurgence, which was what we saw in the first wave. At this point, the curve flattened. It was sustained for a while, but sometime in November, December, we started seeing rise. So, and if we understand how the distribution of this pandemic or the virus, see that we are getting surges in some countries. See what's happening in Iran, in Thailand, in Brazil, in India,
in France too.
Even in France. So, so, and most times you see that we are always trending by, say, 3 to 6 weeks behind these countries. And you ask yourself, what is even the driver? Movement. Of course, people move from India to Nigeria, from Brazil to Nigeria. So once people who have these variants or these viruses that are able to spread across board, you start seeing surgery, you start seeing cases begin to trickle in. Before you know it gets propagated and moves. So what we are doing now, what we should be doing, is to ensure that, one, having understood that we have been able to some extent, contain the spread, which had actually implied a lot of work. But most importantly, we need to ensure that the non-pharmaceutical intervention, including use of face mask, avoiding overcrowded places, all these things that we have been told, all this we will still maintain them. Because if you check India, experts say that at a point there was a big relaxation there to this intervention, and when it came, it couldn't be contained. So, like in Edo, I always use Edo as a reference point. I found out something very interesting. Normally, when the second wave came, obviously the second wave should always be higher than the first wave, even third wave, because it's a matter of being sure-footed. When the viruses or the mutants are sure-footed, they have gained more ground. Whenever they come back, they are always stronger than the initial.
They come with different variants.
Yeah, so what we can do better, which I want to use the Edo experience to portray, is that during the second wave, our surveillance was very strong that November. We were very watchful. We were watching what was happening we were also using local intelligence to begin to know when people started making complaints, rumor management. Immediately we started seeing some signals. We increased our surveillance and our testing capacity.
Okay.
And at the end of the day, do you know what happened? By the time we are now seeing that the second wave has gone down, we began to compare our data with other states, say Lagos, FCT, and other states that tested well, because you use people that test enough to make a reasonable comparison. We found out that we recorded lower number of cases in the second wave than most of the states. If you see our epic curve, you see that our cases are very low in second wave than first wave. What does that mean? The interventions, like, we did enforcement here.
Yeah.
We made mandatory. We did, even people were tried, there was a lot of grassroots engagement. So the interventions were so much on the spread, such that we could not record. And the implication is that less number of people died, less number of people contracted the virus. So if we are trying to replicate same now that we're at the low level in this second wave.
Okay.
So that should the third wave come. And that is what I expect the states to also, the other states to also do.
Okay. Now, beautiful. Now, just like what you said, that the surveillance in Edo State is high, there's no doubt about it. I have seen seen the officers at times going around to ensure that people just, stay with the protocols that you're supposed to observe. But one thing that we must also talk about is Edo State is a transit state to other states. Now, I want to ask whether the surveillance in Edo State, if it involves and includes monitoring the kind of people that come to Edo State and in and out as it relates to the spread of the COVID-19.
Okay, yeah, actually, because where you are going to is very critical, because we are saying if there will be a third wave, where is it even going to come from? It should be portal of entry. Take for example the airports.
The ports. Yeah.
If we have any airport or even the land borders, very sensitive land. But strategically, you say transit. I think when we try to do some risk assessment, we mapped the airport as an area as the area we need to really pay attention, understand the persons that are coming from outside Nigeria that are coming into Port Harcourt and coming into Edo State and follow them up. So that's actually where our surveillance, our satellite, so much on the airport as at present. But we are still using our various surveillance officers at borders to also monitor on unusual events around.
You mean the land borders?
Yes, the land border around those axes. But we are very mindful on the ports, especially airports. We have sensitized them. We are closely monitoring activities there, because if you understand the distribution of COVID-19, should there be third wave, most people who come into the state that have come from outside the country are more likely to fly into the state.
But why do you think the attention is more in the airports? Because most of these aircrafts, their own management, they also ensure that they have a way of checking whether their passengers are free from COVID-19 or not. But for the land borders, travelers coming into Edo State. Take, for example, somebody coming from Lagos. He takes a bus in Lagos. He comes to Edo State. So don't you think the attention should be more on land borders rather than the ports?
Yes, I say that we have our attention in those areas, but when you do your research, where is your problem? Where is it going to come from? What is even the problem? The problem is we don't want variants, or we don't want people to bring a kind of type of COVID-19 virus that would actually spread again.
Yeah.
So we now say, is it more likely to come from the land border or from the airport? It's more likely to come from. So we will concentrate on that. But that does not mean that other maps, areas that we identify as a risk zone, will not mount surveillance there. I don't know if you're getting the point. So it's actually to prioritize what you are doing, understanding where your problem is likely going to come. But it's actually not an Edo thing, it's a national thing. I think it's time for the nation to begin to strengthen our surveillance at this point of entry, because that's where we have we have the water. The point of entry do not only talk about the airports, we talk about the land borders, where we have borders with some people who have affiliation with these countries that we're talking about so much. We have the sea border. So those are the areas that as a country now will begin to tighten and also continue our testing.
Okay.
So that
now,
any unusual event will be
beautiful.
able to
You talked about the Johnson & Johnson vaccine that Nigeria is making arrangements with. And of course, you said with effect from June or July?
I think the expectation is anytime, sometime May, June.
Okay.
But the Johnson & Johnson is also coming with other COVAX facility, the one that we assess through WHO. Yeah. So, but that one is May, June. Okay. The Johnson & Johnson is
but
still...
my concern is on the vaccine, the Johnson & Johnson vaccine,
Okay.
because I remember when the AstraZeneca was to come, a lot of people expressed the fear if we have the ability to actually preserve this vaccine. And of course, it came because of the way the vaccine is itself, that does not actually require low temperature because of our power issue and all that. So it came and we started using it. But for the Johnson & Johnson vaccine, that requires very low temperature. Do you think we can sustain such? Do we have the ability to use Johnson & Johnson if we start using it? I mean, going with our power issues and all that?
Actually, the issue of sustaining the temperature, the cold chain, is actually not a problem. We always had, just like I've always said, we always had a very good record in terms of vaccination, because we have actually aggressively dealt with polio, and we're able to stamp out polio. So when it comes to storage, I think we have people who understand what cold chain is, that have been trained and retrained and trained and retrained over time because of the series of vaccination campaign, measles, yellow fever, and polio that we have done. And we also have those facilities on ground, those cold storage facilities on ground, which we did not just start acquiring because of COVID-19, but because we are doing something similar to vaccine deployment for now. So I think in that area we won't have actually a problem. And you recall, this one is also one dose, it's a single dose vaccination. So once the deployment, once the rollout comes out, before you know it, it's actually deployed. Unlike the AstraZeneca that we still need to store for another maybe 6 to 8, 12 weeks before deployment.
Okay. Now, a while ago, we talked about the surveillance, and you also mentioned that as a member of the enforcement team in Edo State, I don't know whether your team has taken notes. If you go to social gatherings in the metropole, in Benin City, other parts of the state, you still find people not observing the non-pharmaceutical protocols, such as using face masks and all that. I was in a barrier during the weekend, and I can only tell you that a very small amount of people actually had their face masks. Most people just put it in their pockets and all that. So it appears that we are losing grip on the enforcement.
Okay, yeah, actually, just like I told you, some of these decisions that the government take, which most times we try to present the data well interpreted, that will now drive the policies they will be making on this matter. They are very painful. Knowing full well that an average person does not like to wear face masks. Obviously, it's our job to make them understand why it is important and what benefit it gives to them and the society at large. But over time, when the positivity rate, that's the level of infection as we were monitoring, was very high, there were a lot of aggressive moves on trying to ensure that this enforcement started. But now what we are doing is more of sensitization, but the enforcement team is still working. In fact, now what we are beginning to, as at the last technical meeting we had, what we are now beginning to emphasize that we would still have to take some of these difficult decisions.
In Edo State.
In Edo State, because look at what happened to India. It's a singular event that people came and gathered.
It just blew
You
it
understand
up.
me? So these things, they are not far-fetched, and just like you said, we have the same demographic distance with them.
Yeah.
So who told us that it's not possible? I know God has been so good to us, but who told us that it's not possible? So these are the reasons why some of these measures could be put in place. So but the bottom line is that we have to have this in mind until a reasonable amount of our population, at least 60% of our population, gets vaccinated. Some of these measures, we may need to continue with them. Otherwise, we'll be in and out of this.
That's the measures in enforcement.
Yes, ensuring that these non-pharmaceutical interventions are carried out and have a targeted way of enforcing these things. I think the experience in India and other countries should even make us understand that when government says this is what we do, it's out of love. We don't want this country to get into another crisis.
Okay, but doctor, I know you are a medical doctor, but don't you think we should begin to probably look inwards as it relates to the production of our own vaccine? I mean, only a few weeks ago, there was a virtual meeting in Addis Ababa in Ethiopia, of which Igbonedio University was also there. Our own CMD, the SMO of Benin, Chief Dr. Gabriel Sawa Igbonedio, was also there. And he spoke on the need for us to look inward and see how we can produce this vaccine locally. Now, Igbonedio University is spearheading that now to see how they can actually produce a homemade vaccine. So don't you think we should begin to look inward? Because it appears that the COVID-19 is overwhelming the availability of vaccines that we have globally.
Yes, this actually one of the things that the African Union, because African CDC is actually the technical agency of the African Union, with headquarters in Addis Ababa, that try to help coordinate how member states handle public health issues like we are seeing now. So the major thing in the table is how we can fill this very, very big gap that has actually dealt with us so much. Because if you check, Africa is the only country that has done the least deployment. So assuming issues begin to worsen, everybody will begin to protect his own people, then where do we get help from? So actually there has been this meeting we talked about, there have been series of them. And what is the target? One, do we begin to, there are three, the short term, medium term, and the long term. The short term is, how can we begin to do this technology transfer? People, because the Westerners, we are convincing them, these things you are doing, if you transfer this technology, it's not going to, because
but why don't we try to develop our own technology? That has always been the problem.
Yes.
Do we need to rely on
what we're doing now? I said, when you have a problem, you have to find a way of solving it. The first one is, how do we begin to have centers in Africa immediately where we can begin to have this technology existing already on what you are doing in your own production? Training our people to begin to still use the same technology and have these vaccines produced. That's the first one. Number two, how do we begin to build manpower now? Begin to develop research that will help us to do this vaccine production in line with best practices. Because if we produce in Africa, it's also going to be certified by regulators. And also, how do we begin to build institutions, build networks of researchers that will begin to do these things? So these three approaches the discussions have already started. Number one is the technology transfer. Number two is beginning to build institutions, network institutions, and invest in research for vaccine production, because we have seen the importance. And the African Union is actually spearheading that talk. They are actually spearheading that talk through Africa CDC. And I think in the nearest future, but one of the advantages we have there is that the Westerners now understand that even if you succeed in taking out, vaccinating everybody in the US, somebody in Africa or in Asia still has COVID-19. It's a threat to everybody. So it's a win-win situation. So I think these discussions are going to be bearing fruits. But most importantly, like you said, what does Africa do to become independent in terms of vaccine production? So this is the time that these discussions are on. And I can assure you, they have designated 3 centers of excellence where we are going to be doing a lot of studies and research on vaccine production in Africa. Each regional coordinating unit in Africa will be having 1 center. So West Africa, East Africa, Central Africa, North Africa, and Southern Africa. So we have actually gone a lot of miles. But African Union is coordinating this in terms of having these centers. So it's actually it's one of the things I want to come out with after this pandemic as an African, that at the end of this pandemic we saw the need and we aggressively pursued the need.
And we developed our own vaccine.
Yes.
All right.
So it's on course.
All right. As we conclude the discussion this morning, now let's look for a way to urge our viewers out there, on the need to really follow the pharmaceutical protocol, because it seems, well, I understand that a whole lot, have happened during the week in the nation, the insecurity situations and all that. So that may just be responsible why people seem to have forgotten that we have COVID-19. So this third wave that looms in Nigeria, how do we really begin to prevent it so that it doesn't come to our country?
Yeah.
So that we don't experience it.
So one thing is, we should know if we had a first wave, and after a while the second wave came, and the possibility of a third wave is not rocket science, it's not actually being pessimistic, it's actually being realistic. So the possibility of a third wave in Nigeria is there. Even if it did not happen, even if we're not seeing what's happening in India and other countries, we know that there are still possibility. But these happenings around the world should also help to open our eyes for some people that don't understand how these things work, that we need to continue to obey all these non-pharmaceutical interventions, like the use of face masks, always washing our hands, avoiding overcrowded places. You recall that event centers, activities in congested and crowded places are actually driving this spread in other countries. That's why we kept on saying earlier, avoid these 3 C's: crowded places, close contacts. Crowded places, close contacts. We should make sure that we avoid places that are crowded and closed doors or closed settings. And that, like, if you are in a closed setting, know that you are at risk of getting COVID-19, especially when so much people are there. If you are having a close contact with somebody, know that you also have a risk of contracting COVID-19. If you are in a crowded place, also have that understanding. Use of face mask is very important. Always washing our hands, because the virus does not stay long, and most of the transmission spread are always droplets on surfaces that people come and pick. So these are the things. And also the pharmaceutical intervention, the vaccines. In India now, you don't need to tell somebody to go and take vaccine. People are scavenging. In fact, that's why they say we
heard the vaccines are even scarce in India.
They're very scarce. They are just as scarce as gold. But I recall the last time I came, I said, must we wait? I always use that, must we wait for it to get this bad? I recall when we were asking people, get vaccinated, people are saying conspiracy, bring in a lot of conspiracy for something that is going to save life. Now, people some other place, not far from us, can do anything now to get a dose, a jab. But we shouldn't wait for that, for us to get to that level. We should understand when the cloud is thick here in this part of Benin, I shouldn't be told that very soon it's going to rain here, and if it rains there, it's going to rain somewhere in GRA. So these are actually what I want our people to understand, because we can't afford further crisis. We're already having insecurity, and we want to bring public health crisis. Is very, you could see where in India every day about 2.5 million, 2,500 people die. Barely 3,000 people die every day in India, and barely 300 and something, a third of a million get infected. And this is
but
actually
that is
underreported.
also,
We are assuming that it could be underreported.
yeah, yeah.
So
because it's also subject. I was going to say that's subject to investigation.
Investigation, because
yeah.
it could be underreported. You can't compare the report we have from a developed country with this developing country. So in that underreporting, or you could see that a lot of things are happening. So, and in their first wave, they were just like us. No, it was happening in US. No, they were just relaxed. All of a sudden, they were just like us, and we began to. So I think I want to use this opportunity to ask our people to understand that we are in this together. We cannot afford any crisis, public health crisis. Let's be asking God to help us in the crisis we're already in, so that we cannot, and we can only achieve this by following all these measures.
Yeah. All right. Thank you so much, Dr. Pius Ononigwe. From the CDC, that's the Center for Disease Control, epidemiologist with the Edo State government, and also a member of the enforcement team, that's the COVID-19 enforcement team in Edo State here. Doing a great job to ensure that the COVID-19 is brought to standstill in Edo State. Now, we understand that India, it's almost under lock and keys as it stands now, because of the COVID-19 situation in the country. Now, we must ensure that we don't leave our thoughts aside. Insecurity issues are there, there's no doubt about it, but we must remember that there's COVID-19. There's still need for you to observe the non-pharmaceutical protocols, such as always ensure that you wash your hands. Once you see a hand sanitizer, always ensure that you sanitize your hands, and ensure to go around with your face mask, most especially in crowded environments, so that you don't be a victim of the COVID-19. Thank you so much, Doctor, for finding time to come. Thank you so much.
Thank you so much for having me. It's a great pleasure.
All right, viewers out there, the program is still this morning on ITV. Other segments will come your way. Please stay tuned.